Okay, let's get started. Thank you all so much for joining us for this week's Miami Global Brain Tumor Symposium. My name is Michael Ivan. I'm one of the directors of the symposium, and I'm joined by my co-directors, Dr. Komatar, who's a professor and program director of our residency program here at the University of Miami. He's also the director of our surgical neural oncology program. Dr. Morcos, professor and the co-chairman of our department here at University of Miami. He's also the director of our cerebrovascular and skull-based program. And Dr. Benjamin, who's assistant professor, brain tumor and skull-based specialist, and she's the director of our skull-based lab, the Keynes Lab. So each week we put on these symposiums, and we couldn't do that without the tremendous help of our administrative team. Christina, Ingrid, Ignacio, and Roberto all have done tremendous. I think this is our 15th symposium, and we really cannot do it without them. So many thanks to them each week in the past and going forward. If you're interested in learning more about our symposiums here at University of Miami, we're active on social media, YouTube, Twitter, and Instagram. Also, you can go to our website where we have more information. We have symposiums for residents, medical students, as well as for skull-based cerebrovascular in our tumor symposiums. And each week we post what's going on with them. Also, all these recordings are on YouTube and posted and saved, so you can watch them at a future date at our departmental YouTube site. So this is just a quick teaser. So on Thursdays at the same time, Dr. Morcos and the rest of our team here put on a cerebrovascular and skull-based symposium. Tomorrow we'll be talking about lesions of the petrous apex with one of our ENT colleagues here, Dr. Angeli, as well as Dr. Araz, talking about different approaches, pathologies, and ways for surgical resections by the panelists, Dr. Gentili, Dr. Nanda, Van Gumpel, and myself. Also, a teaser for next week on our Miami Global Brain Tumor Symposium, we'll be welcoming Dr. Carter, who is the chairman at Massachusetts General Hospital and Harvard Medical School, to be talking about personalized brain tumor diagnostics and therapy. So make sure you turn into that. I'm sure it's going to be a great talk. Before we start this week's symposium, a quick housekeeping. So please use the Q&A button. We try to make this as interactive as possible each week. We don't offer any CME, but you do get an email confirmation tomorrow documenting your attendance. And please be sure to like, follow, and share our videos on Instagram, Twitter, and YouTube so that we can continue to grow and share all the outstanding knowledge that our excellent speakers and panelists will give to you tonight. So this week we have an excellent panelist team. We have Dr. Raza joining us from University of Texas and MD Anderson in Houston. He's the vice chair of their education department as well. He's a brain tumor and skull-based specialist. We have Dr. Zachariah, who's associate professor and co-director of the neuro-oncology program at Penn State. He's also director of the brain tumor and skull-based program. And Dr. Linda B., who's assistant professor of neurosurgery in their skull-based and pituitary center at the Harvard Medical School at Brigham. Thank you so much to all of our panelists for joining us this week. Very, very special guest we have this week joining us, Dr. Cohen Gadol. I think one of the most world-recognized neurosurgeons, and probably doesn't need introduction, but he's the director of neurosurgical oncology, professor in the Department of Neurosurgery at Indiana University, where he's world-renowned for his expertise in brain tumor, skull-based, aneurysm, AVM, and microvascular decompression surgeries. He's a huge part of their department. He's also president and CEO of the Neurosurgical Atlas, and I'm sure everybody knows about the Atlas. It's probably the preeminent go-to resource for neurosurgeons, both in training and in practice, to learn both from their YouTube videos and outstanding animations about different techniques, approaches, positioning, didactics, job finding. I mean, he really covers everything that you need to know, and has done such a great job ever since 2016. I think it's probably been affected by every neurosurgeon in the world by now, his resource, and for that has been kind of the staple as far as what to do and what not to do. And we thank him so much for all the time and effort that he's put into that resource. He's also associate editor for the Neurosurgical Focus, as well as editor for multiple other journals, and he's also one of the directors for the Cure for Glioblastoma Center at Indiana University. So Dr. Cohen Gadol, I can't thank you enough. I know you're extremely busy, but for taking out the time this week to join us.
Thank you again, Mike, for giving me the opportunity to be here today. It's truly an honor. I think the Miami group, including Jacques, you, Mike, and everyone in the department, and Ricardo, have done a huge job to bring the virtual education to a new level, especially at the time of the pandemic. So it's an honor to be here again, and I appreciate the opportunity. Mike, you asked me to talk about Pioneer Region surgery, and it's quite a coincidence because I never thought somebody would know so much that I love Pioneer Region, and actually is one of my most favorite places next to Cerebral-Pontine Angle area. So this is the topic that Mike wanted me to talk about, and I'm very excited to talk about it. Before we go there, I want to tell you something that has been very dear to me, and that's history of neurosurgery, something that I was very much involved with creating the book of the legacy of Harvey Cushing and all the collection that is no longer in the basement, but in the Cushing Center, including, as you can see here, 15,000 of the glasses that contain the patients of Cushing's images. And here you can see Harvey Cushing at the peak of his career. These are images not often seen, and especially here in posing with the patient. This is a patient obviously with acromegaly. Among the 15,000 images of patients, there are only 2 images, or actually one, that Cushing intentionally appeared with the patient in the image, and it's actually a patient with acromegaly. And it really shows the obsession of Cushing with endocrine disease and pituitary surgery, and really something that started neurosurgery for Cushing. It put him literally on the border of being a neurosurgeon operating on the brain. And if you read some of his private letters at the end of his life, you can really feel his true appreciation of what pituitary surgery did for him early on as he founded neurosurgery, or modern neurosurgery. This is Anna Aronson, I think a 12-year-old girl who was diagnosed with a teratoma. You can see the tumor in the right lower corner. Her tumor was lost after it was removed by Cushing when he actually did the autopsy under operating table, because the patient wasn't doing well during her second surgery, and removed the tumor. And these tumors were very important for Cushing in order to understand their natural history and approaches for resection early on. And as this tumor was lost, Cushing was very much unsatisfied and created the brain tumor registry that has been the foundation for creation of neurosurgery in the United States and North America. So, and the brain tumor registry maintained all the tumor specimens that were no longer sent to the pathology department. And that was really the reason for that to occur. This is a video of Cushing operating early on. I thought it's fun to share because all neurosurgeons love history so much. There's some audio with it. I'm going to go through it pretty quickly when Cushing appears, and shows his 2000th brain tumor operation that he celebrated. Very extremely rare occasion for Cushing to allow the cameras to attend in the operating room when he was so obsessed with sterility. Some of you may have seen it, but let's go ahead and have a look.
The film opens as Dr. We recall one day when 2 small boys climbed up into one of the... If you boys cannot keep quiet, I shall have to... Including the Russian physiologist Pavlov, whose long beard, since he refused to wear a full mask, almost touched the open wound. Dr. Cushing was tolerant of these visitors, just as he was patient with the rotation of house officers.
You can see the craniotomy, how they use clamps for hemostasis at the scalp edges. Here's Horax, one of his attendings, one of his residents initially, eventually became his attending, and did all the opening and closings for the professor.
One of the important people in the operating room was this husky man of German descent named Adolf, who may well have been an arrested acromegalic. He ruled over the operating room like a master sergeant in a boot camp.
The Let's go ahead and move forward a little bit.
Gilbert Horax. Shown here, a beveled saw cut was made from within outward on all but one side, and forcible breakage of the temporal bone laid back the flap. Then the operative field was made dry. The wound was covered with warm saline sponges, and Dr. Horax departed while Dr. Cushing prepared to take over. Dr. Cushing had an understandable dislike for the bloody practices still seen then.
It's very impressive to see Cushing in action. Actually brings him to life. When you actually see the video, even if the video is from 1929, I believe, still adds a lot of character to Cushing when you see him moving. So let's watch maybe a few seconds of that.
In German operating rooms, where surgeons wore rubber boots and rubber aprons simply to keep dry. Cushing's team wore white shoes, immaculate reminders of the careful hemostasis which was expected of everyone. Dr. Cushing's reaction to the cameras was a mixture of tolerance and impatience. The photography was done with his permission, of course, but the details bothered him, and he tried to control the scene taking. When he felt that something was unimportant, such as the scrub.
Really, the film era that you can see in that time. Here is actually a picture of Harvey Cushing's patient, as you can see, with a pineal region tumor. And he could not localize the tumor when the patient was living. The patient died in the hospital, and he as you know, some of these brains were harvested under unknown and inconspicuous conditions that probably wouldn't be legal these days. But when Cushing was found actually in the morgue late in the evening, trying to harvest things out of patients who may have not provided, or the families may have not provided consent. But either way, here's the patient with the Pernot syndrome. Here is his brain afterwards. This is actually the only record that we could find of a patient with a pineal region tumor that Cushing initially studied. As we know, Dandy was very instrumental in approaching pineal region tumors. This is almost over 100 years ago that Walter Dandy described the posterior interhemispheric approach to a pineal region tumor in dogs. So this is nothing new. The approaches are not new. And here I'm going to just show a short video of the Neurosurgical Atlas and describe some of the new projects we have, including the Virtual Brain Project, which has created the brain, the vessels, dura, every component of the brain, and approaches in 3D using virtual reality. It's been a very fun project working for the Atlas. This Atlas that many of you are very familiar with, really 520 chapters, is the most comprehensive collection of microsurgical techniques. It describes the unspoken pearls that really have not been clearly defined in any textbook, especially with the surgical videos. I spent over 5 years editing 15,000 hours of operation, and reviewed over 4,000 complex cranial operation to be able to really create a collection. It has 1,200 videos, 150 webinars, 30,000 web pages, over 9,000 illustrations. Membership to date is 40,000 providers internationally, and the average daily number of viewers is 2,000 per day. Here you can see really the beautiful artwork. I'm really very much in love with art of microsurgery, and some of our talented illustrators that really create work that is unparalleled. Let's go ahead and talk about the agenda, diagnosis, imaging, literature evaluation, and approaches, illustrated cases, and some personal reflections on pineal region tumors. I like to show this video in many of my presentations first because I love the sitting posture. It provides a lot of stability for the hands, especially when you have your hands resting on the armrest. The mouth switch is absolutely critical, makes the microscope a piece of the surgeon's face. It decreases the time of surgery by almost 30 to 40%. And so I think those two key factors, the armrest, as you can see here, and then the mouth switch are just critical for us to be able to effectively manage things and only use the armrest as necessary. You can see the assistant across the table from me, the mouth switch one more time, just such a critical component of what we do. I want to attract your attention to this article, The Art of Microneurosurgery and Passion for Technical Excellence. It's something that I thought about for many years until I wrote this paper in Journal of Neurosurgery at Brokaw's area, which describes so many of the details in terms of advancing from a novice to a master neurosurgeon to perform deep-seated resection within the intracranial space. The foundation for the discussion today is this paper, Lateral Supracerebellar Approach. I have not performed a midline suboccipital approach that is the most common approach to the pineal region the past 12 years. That is very unusual, and that's why I want today for everyone to understand that you can remove almost any size pineal region tumor, no matter how large, through a very minimal, small lateral supracellular approach with excellent results. This is minimally invasive, provides you excellent exposure, and protects so many of the structures. This is another paper that we describe some of the techniques, the posterior transcostal approach in operative neurosurgery that I'll talk to you about. The presentation of pineal region tumors is very standard. All of us know very well about them. I'm not going to go into the presentation of hydrocephalus, Pernot's dorsal midbrain syndrome, Opgaze palsy, all that are something extremely basic. Obviously, CT, MRI, MRV, CTV are important to define the diencephalic veins. Most often we do an ETV or biopsy if the CSF markers for germ cell tumors are negative. And it's important to know that 1/3 of these tumors are benign and really nicely amenable to resection. And if the tumor is non-germinalis, I think an open biopsy and resection is very reasonable. But please do understand that most of these tumors can be easily diagnosed as pineal region tumor and germinoma if adequate testing, both in blood and CSF, are done for the markers. Obviously, it's not good to operate on a germinoma as it's so well managed via radiation. Rare case is the boy around age 11, 12 who presents with or without diabetes insipidus, which is classic for germinoma, and not even a biopsy or CSF study may be necessary. These tumors can really mimic each other. This is a germinoma. This is a pineoblastoma. You can see the enhancement patterns and location and the way they appear are very similar. This is a glioma of a tectum that, as you can see, mobilized the vein of Galen posteriorly, and this is such an important factor that should be considered in selection of the operative corridor. Where are the deep veins? And we definitely don't want to have a venous infarction or increase the risk of it. This is a pineal cyst where surgery plays a minor role, and a pilocytic astrocytoma. Again, some of the spectrum of the images or imaging findings. This is also very basic. All of us know this very well about, is there hydrocephalus? Did we send the markers? Are they positive, negative? And if they're negative, open biopsy versus resection versus ETV. So I'm not going to spend too much time because our time is limited today, but definitely refer people to the Neurosurgical Atlas for further detail about the decision-making process. The supratentorial approaches to the pineal region are very classic, occipital, transtentorial, and suboccipital, supratentorial, and obviously subtemporal, which is rarely ever used. The most common approach is the midline suboccipital, which I think is Not necessary. It really requires manipulating the torcular bilateral sinuses, taking a lot of the midline bridging veins that leads to cerebellar swelling and make the operative corridor very difficult. As you'll see today, which I hope I can convince you, is that the very small lateral infratentorial suboccipital approach is more than adequate. You only manipulate one of the transverse sinuses. You don't touch the torcular. You don't place the midline bridging veins or tentorial veins at risk. And because the cerebellum really is like the wings of the cerebellum have a slope more inferiorly laterally, actually the exposure is very nice. You don't fight the Coleman. The exposure is excellent. Minimal retraction of cerebellum. Cerebellum is very relaxed because you haven't compromised and sacrificed the midline cerebellar veins. And I highly, highly recommend all of you to try this approach. And I know many people have some concerns because, well, this is not what I'm used to. But again, one of the most successful neurosurgeons ever told me that the dogma is the first reason why neurosurgeons are not innovative. And so I think it's critical for us to try new things, minimally invasive, do more with less exposure. Again, doesn't mean that you just have a smaller exposure, but your exposure leads to a lot of brain injury. You have to protect the neurovascular structures and at the same time have a very small opening, essentially a minimally disruptive exposure rather than minimally invasive or smaller exposure. There are rare tumors that are located very much just in the superior velum and just in the roof of the fourth ventricle and may require a combined approach at telovelar and supracerebellar. And again, those guys are very rare. So again, my personal reflections before we start is careful preoperative evaluation, avoid unnecessary surgery for germ cell tumors. The paramedian supracerebral approach is excellent. Surgeon's experience and comfort level is extremely important. Pineal lesion is deep. It really requires very much bimanual and very good command of microsurgical techniques, using the mouth switch, staying always in focus, because when you're working that deep, any minor movement can put the image out of focus. And if you have to place everything in focus, give the instruments back, focus again and get the instruments back, by the time you get the instruments back, the operative field is still out of focus. And I can tell you, having that dynamic retraction, a very bimanual dissection. The suction is not just sitting there, not doing much besides sucking fluid. The suction is actually not only a dissector, not only a dynamic retractor, but it does so many things. And you'll be amazed if you really do that bimanual dissection and take advantage and maximize the use of your suction and just use a suction to retract in the exact location of work, rather than using those wide fixed retractors that actually retract less because you're fighting against such a bigger surface of the cerebellum. You'll find that you can do so much through smaller corridors and very deep with maximal preservation of neurovascular structures. And ultimately, just anywhere in tumor surgery, the texture of the tumor, how suckable it is and soft versus how vascular and firm it is, can make a big difference in terms of the corridor it's required. I have had a significant interest in pineal region tumors because they're so challenging and provide an opportunity for a surgeon to prove his technical acumen and excellence. And 121 cases within the past 15 years. The germ cell tumors were not germinomas. There were tumors that obviously had non-germinomatous components, pineoblastomas, cavernomas, meningiomas, pilocytic tumors, gliomas, epidermoid cysts, and very rarely symptomatic pineal cysts. And I can tell you that at least 20 pineal region tumors are required for the surgeon to reach the technical skills necessary for managing these tumors. And obviously understanding the anatomy, especially coming from the lateral supracerebral approach where the exposure is distorted. And I will talk that in a moment. Midline suboccipital craniotomy, you can see the standard technique. This is extremely basic. We all know that too well. Taking the central vein, open the thick arachnoid bands, dissecting the tumor, debulking, removing it. This is a pilocytic astrocytoma. The only thing I want to emphasize is that when you initially use the microscope, if you just follow the tentorium and the surface of cerebellum, you're going to end up at vein of Galen and critical structures. You have to remember when you get close to these veins, you really have to change the angle of view for you to be able to get to the tumor. So if you just follow the cerebellum, and this is a common mistake for novice surgeons, you end up in no man's land. You open the arachnoid, you get lost. You don't know where you are, where's the tumor, and often the arachnoid band is so thick that it's difficult to find where the tumor is, and the tumor is so much the same color as the other structures, nervous structures around it, that unless you're very careful about changing this operative view, it can become challenging. So let's talk about my favorite. It's lateral supracerebellar. You can see the approach here, very standard. Rather than coming from the middle where you have to put a retractor, really push the culmen down, you come laterally, you can see how much exposure you have. You see a good portion of cerebellum, you see the pineal region, you're coming from a lateral trajectory, all these midline cerebellar veins are protected, and really provides an amazing panoramic view, and you can get both sides of the tumor, but you have to remember that the third ventricle is distorted here, and I'm going to show that momentarily. Again, you can see these beautiful artistic work of our colleagues. Josh here, the tumor, how it pushes obviously the posterior part of the superior brainstem and goes in the third ventricle. You can see the trochlear nerve and how other venous structures, vena Galen, cerebromedullary vein, and the basal vein of Rosenthal are displaced, and obviously some of the branches of the superior cerebellar artery. So here again, you can see a lateral supracerebellar approach, and I'm going to review with a video. Here you can see by hiding some of the tumor, where is the location of the third ventricle, and it's completely an angle with you. And I'm going to show that in a moment. So this is a magnified view of the tectal area and the pineal region. The tumor is sitting here. You can see how the third ventricle is to an angle. So when the tumor expands this, if you just go straight, you're going to injure the contralateral thalamus. This is exactly like approaching a olfactory groove meningioma through a pterional versus a bifrontal approach, and approaching a pituitary tumor from a unilateral nasal approach where it pushes you to the contralateral area. Here's the anatomy again, showing the venous structures, the third ventricle, and here you can see the outline of the third ventricle that you should be very aware of in this very disorienting approach. Here again, you can see the fourth nerve early on exposing the tumor. You can see the vein of Galen on this pineoblastoma that was very adherent tumor. Here you can see the tumor and ultimately removal of the tumor. You're looking through the third ventricle, but from an angle. And I think that angle is critical. So we talked about this, the paramedian infratentorial supracerebellar approach, and that places one of the sinuses at risk. It spares the toricula, minimizes cerebellar retraction, and maximizes and minimizes the risk to supracellular bridging veins. Here's a video that I'm going to go through describing, again, the supracerebellar approach for this pineoblastoma.
Relatively heterogeneous, well-defined mass in the area of the pineal region. There was also some mild hydrocephalus of the midline. 1/3 of the incision is above and 2/3 is below the transverse sinus.
So here you can see the incision is just between the mastoid groove and the midline. It's 1/3 above the sinus, 2/3 below. You can also have mark a place for a ventriculostomy if you need it, using stealth neuronavigation. Patient is in lateral position. You see the head's turned slightly to the right. I'm a left-handed surgeon. I will use any reason to operate from the left side. But in this case, you can see the venous system is less important, most commonly in humans on the left side. The arteries are more important on the left side. So because the venous system is less important, I choose the left side, but you can choose the right side if you're right-handed. I think it's going to be very difficult for a right-handed surgeon to operate from the left side with the patient in this position. And I want my colleagues to consider that.
More exposure. Branches of the superior cerebellar artery.
And here you can see that we're opening.
Here's the midline, incised, and the tumor is aggressively debulked. This tumor is quite fibrous. Extraocular movement abnormality after surgery. These deficits resolved within 2 weeks. You saw a view of the posterior aspect of the third ventricle a moment ago. You can see the vein of Galen. Further attempts are relatively non-conclusive in terms of, here are the bilateral walls of the third ventricle. MRI demonstrates radical subtotal resection of the tumor with potentially small residual tumor adherent. Relatively heterogeneous
postoperative MRI on this patient.
An important consideration during resection.
This is an interesting case. I showed the images. This is a young patient who presented with hemorrhage within this glioma of the tectum. And it shows an excellent example of how you have to be very careful, and the veins are so critical. So let's go ahead and review this also briefly.
Of pineal region masses is the location of deep veins, including veins. In the emergency room demonstrated acute.
Here you can see hydrocephalus. This patient received a ventriculostomy, and here you can see the tumor very much infiltrating the thalamus. Looks like a glioma and a large hemorrhagic tumor with the vein mobilized posteriorly. One may say that a occipital transtutorial approach is a better approach for lesions where the vein can be obstructive, but through the lateral cerebellar approach, I really have had no difficulty managing the veins because you're coming from a lateral trajectory. In fact, I have not needed to use the occipital transtutorial approach, no matter what is the location of the vein, and that's something very flexible about the lateral supracerebellar rather than the midline suboccipital approach.
Cephalus, and an important cut of the Paul out.
Here you can see again the positioning of the patient, the location of the transverse sinus. Here's the craniotomy. You can see the transverse sinus. I usually remove some bones so I can tack it up and mobilize the tentorium superiorly.
The transverse sinus can be mobilized superiorly. The trajectory is developed. You can see that the cerebellum is tight in the region. Here's the falx cerebelli. 2 stitches were placed along the posterior aspect of the cerebellum.
These retraction sutures on the posterior aspect of tentorium can really elevate the transverse sinus and give you a few more millimeters that can be so effective in these situations.
To mobilize the transverse sinus superiorly and expand the operative corridor through the supracerebellar trajectory. You can see the hemorrhagic mass is evident early. Small cortical incision is made and the tumor is entered. You can see the hemorrhagic mass. Again, an important consideration is the location of the deep veins that could be very much engulfed by the tumor. Small cuts are made to assure that no important neurovascular structure is endangered. Here's the capsule of the tumor more on the left side that is being exposed. As you can see here, I tried to take a bite of the tumor relatively blindly And in a moment you can see one of the veins just about there was.
Here is just one of the important veins very much engulfed within the tumor. And this is a statement I often make to my fellows and say, it's not even once okay to say there it was and be right, but it's okay to say 1,000 times there it is and be wrong. So as you can see, if you're not careful in these lesions, this vein, which is actually the vein of Galen, would have been torn. So at every time, the surgeon has to be looking carefully about what's ahead of him or her.
Very much close to be caught within the jaws of the pituitary rongeurs. Again, this is an important point to remember, that in the tumors that are primarily anterior to the veins, within the tectum potentially or thalamus, and push the veins posteriorly, the deep veins can be between the surgeon and the tumor and can be easily injured if there are nerves. I was lucky enough to avoid any injury to the vein. Obviously, a sign that I have reached the anterior extent.
And so, as you can see, that was really another method of removing tumor. I'm going to show the ultimate MRI in this patient. And here you can see a nice resection. Obviously, we can remove the tumor infiltrating the pulvinar, and this patient about 7 years out from his surgery and is doing extremely well. The occipital transtentorial approach is another one. I have never used it because I think it's much more invasive and is utilized for tumors really from the precentral cerebellar fissure and especially multi-compartmental regions that occupy the pineal region in addition to posterior thalamus. Here is an image from Rotan. Here you can see how the occipital orb is mobilized, this tentorium is cut, really provides a beautiful panoramic view of the pineal region, but again, it's much more invasive. If I had to do it, here is the way I think can be done relatively easily: craniotomy, mobilization of the occipital lobe, cutting the tentorium, obviously recognizing the veins. There's different kinds of variations of locations of the veins that you can see that the veins can be in the way. And then the posterior interhemispheric transclosal intravenous paravenous variant that I have used, described by Dandy, where you remove tumors that are very much in the posterior third ventricle, like a tumor such as this, that has its predominant component in posterior third ventricle and then comes back into the pineal region. Here's the craniotomy, somewhat a little bit more posterior than usual. You can see the coronal suture here. Here's working through the attenuated version of the attenuated section of the corpus callosum, dissecting the fornices, and then dissecting the internal cerebral veins, getting to the tumor, removing it, and here is the panoramic view of the third ventricle. This is a large epidermoid cyst that I removed through this approach. You can see a lateral approach using retraction by gravity. Really, a linear incision provides an excellent approach. I know we're running a time.
This is a challenging spot of the craniotomy was elevated.
Here's the callosotomy, opening the tumor, removing the tumor in this area, using endoscope at the end, making sure that the tumor is completely removed, and really provides an excellent panoramic view. Obviously, there are minor residual epidermoid lesions that were very much affecting the
hello, my name is
part of the ventricle. So my personal reflections really that as a surgeon in general, the most common reason for mistake is and misunderstanding of how to relate to the gap between what you think you should see or expect versus what you observed in surgery. And if the surgeon can really deal with uncertainty when such a gap exists, it's usually the most common way or best way to avoid surgical complications. So with that in mind, I'm going to make it relatively brief to talk about my advice for residents, but I don't think we have time right now to do it. So we're going to leave that for another
we have
session.
a couple minutes. We have a couple minutes. That'd
We
be
have,
great.
okay. So many people ask me, what is your advice for residents? And here is my advice for young junior faculty and residents is force yourself to set aside time to think strategically and self-reflect. The Neurosurgical Atlas was founded on self-reflection by recording videos, watching myself, and really realizing how much of my maneuvers were extra and inefficient. In fact, I remember the first 3 years, I would edit my videos. I would only review videos. I would only take out the parts that were very deliberate, and I would review all the parts that were useless. And it was absolutely humiliating that in the heat of the surgery, we do so much of our movement is useless. And with time, surgeries that took 5 hours went to 3 hours, went to 2 hours, went to 45 minutes. To the point that today, even a 5 centimeter AVM, intradural part of it really takes less than an hour and a half. And really the part is focusing on what's important, watching yourself, just like the coach and the team of a football team watch the videos of the games the week before they play the opponent. I don't know why as surgeons we don't watch our own videos and get better. We all have a lot to learn. There's no ending to learning. I think when you become a junior attending, your learning really starts. And be clear about your next steps. Be very honest with yourself. What do you want from your neurosurgery? And is where you are located, is that long-term satisfying your career goals? Always make decisions as if you're 55, 60 years old, and you really want to know what you want to see at that time, so you're not disappointed. You are the only person responsible for your value. It's not the nurses in the operating room or the nurses on the floor or the secretaries or other ancillary staff. You don't have to, they don't owe it to you to give you respect. You owe it to them to prove to them that you deserve respect. I think that's something that so many neurosurgeons take for granted. Just because I'm a neurosurgeon, everybody else has to provide respect for me. That's actually wrong. You are the only person responsible for providing the value and proving your value. And build your external reputation. Professionals are always taken for granted in their own organizations. Always look outside. Always remember that you have to do better. You have to provide value. You have to have a good reputation at home, but always remember that you have to have the external reputation for yourself, because they will take you granted where you are currently. Communicate directly and build relationships. Neurosurgeons are often very inept when it comes to social skills, and that's an underestimation, unfortunately. Think about neurosurgery as an entrepreneur. Always think about outside of neurosurgery and how it relates. Get on your MBA early on. There's much more than just technical aspect of neurosurgery. Actually, I would say becoming an amazingly slick surgeon is such a small part of neurosurgery, such a small part. The much bigger one is how you prove yourself as a great communicator, as somebody who is great to work with, and as a great innovator and entrepreneur. Definitely not as somebody who demands respect from others. Be trustworthy, be independent learner, have attention to detail, and manage your times effectively. Just being in the OR all day, don't be proud of that. There's so much more in neurosurgery than just sitting there all day, isolating yourself in the OR and thinking you have accomplished a lot. I always believe that no matter how long the surgery took, I can do it half the time and provide even a better outcome. And that's what you should strive for. Be personal, be professional, be a leader. Don't expect other people to assume you're a leader. You have to prove yourself. And being the operator is not the final goal. Actually, becoming an excellent technical surgeon is easy. I personally thought Or think, if that was the gauge of how great of a neurosurgeon is, that's easy. It's really so much more in neurosurgery than being an incredible slick surgeon. I have learned personally earlier in my career so much from watching others. And that's something our residents and faculty, junior faculty and fellows take for granted. And remember, neurosurgery is beautiful. It's a privilege, not a right. It is the best time of your life to make such a difference for the patient, and enjoy it, be proud of it. And remember that, again, we are very much blessed. We have a God's blessing to be a neurosurgeon, and we have to stand up for the expectations. So Mike, thanks again for the opportunity. I hope this was satisfactory.
That was great. No, that was outstanding. I mean, I think, you know, the anatomy, first of all, those cases are so rare, and so your series is impressive. But the anatomy and coming from the lateral suprasellar trajectory, which I think is definitely the best way to go as well. Understanding that anatomy from a lateral approach, and both your videos and the illustrations just help out so much. And I think it's something that I look at every time that I have to do one of these cases. And then your last thoughts about, for the residents, I think was great. I'm going to play that over and over again for all the residents who aren't on the video today. But for myself, I keep a log, and I keep notes on all the things that I did wrong or could have done better in those cases. And I constantly, every time I go back to the log to put in the next case, those highlighted things come up to me and say, this was inefficient, this was not efficient. And I think that's key to pushing yourself and strive to be better, both in the operating room and out. We have a bunch of questions here that came up, and I just wanted to kind of get to a few before we get to our panelists. One was, for the lateral suprasellar approach specifically, we don't have as much gravity to work with us with the cerebellum, which is what I think a lot of people do in the sitting position. So, do you use CSF drainage, or other than your retraction with the suctions, is there anything else you do, elevation of the head, to kind of get that gravity?
That's an excellent question, Mike. If they have obstructive hydrocephalus, they get an EVD, obviously, through the same incision that I do this surgery. If not, I use lumbar drain very much liberally. I've had an excellent experience with it. But at the end of the day, using that minimal invasive approach, not sacrificing the veins, the bridging veins along the midline, makes the cerebellum so much happier, so much easier to respond to your dynamic retraction. So I think CSF drainage, dynamic retraction, using the movement through the lateral slope or the wing of cerebellum, which is more inferiorly located and therefore demands less retraction, are all those critical factors.
Great. From Elena Lopez, she asked,
yes,
for these small, for the smaller tumors that don't have hydrocephalus, what is the role for biopsy versus just going in and resecting if the markers are negative?
I think if markers are negative and you don't have hydrocephalus, and an exploratory posterior fossa operation, first getting the biopsy, make sure it's not a germinoma, is very reasonable.
Okay. For when you get to the anterior part of the tumor,
yes.
Do finding in the third ventricle is always a very great sigh of relief, because you could kind of find that boundary. What are your tips for kind of getting into the third ventricle, and is that something you always make sure you do early in the case or late in the case?
Yeah, I stay on the capsule of the tumor, and I think it's critical not to injure the tectum too much, although some manipulation and the upward gaze palsy that occurs are temporary. Just stay on the capsule, debulk the tumor, may always have a good view of the forest from 1,000 miles of where you are. Don't zoom in too much. You have to, if you zoom in too much, you really can get lost. If you zoom out too much, you really can do microsurgery. So there's a balance between the two. And stay on the tumor, debulk, stay on the capsule, and the third ventricle will show itself in the right time very easily.
What are your opinions on stereotactic biopsy of pineal region tumors?
Yeah, that's an excellent question. I think that's somewhat risky. I think that's somewhat risky. You're crossing many PL membranes or PL boundaries. I think it can be done, but I believe that the utility is so small because it's either a germinoma or it's something that's relatively resectable and the resection provides benefit. So I'm not sure doing a stereotactic biopsy and coming back to resect is a great idea. And this exposure is so small. I mean, it's just, almost, 2 by 3 centimeters, takes 15, 20 minutes to do, and you're there to do the biopsy. And if it's a germinoma, you can close.
And last question before we get to the panelists here. For the posterior callosotomy approaches, what are the risks that you talk about in particular to that approach to the patient to let them know about, asked by Gianluca?
Yeah, you have to remember that the bridging veins are important, the parasagittal veins. You have to study those, and then you have to understand that I use this approach when already not the splenium. I never touch the splenium to make sure that disconnection syndrome is not likely, but I just dissect a very small part of the posterior body of the callosum. And usually that part is very thinned out by the tumor because the majority of the tumor is close to the third ventricle. So the risk of disconnection syndrome is very small.
Okay, great. Okay, great. Fantastic. So let's start with Shane. If you want to present your case.
Yeah.
Shane, it better be a difficult case.
Uh-oh. All right, can you guys see my slides?
Yeah, looks good. Thanks.
Well, Mike, thanks for having me. It's, of course, a tough act to follow Aaron.
Thank you.
We'll see if this is a difficult case or not, but certainly it's a case, so it counts. So, this is a gentleman I treated a couple of years ago, a 54-year-old who had presented with a 4-month history of diplopia and on exam at a partial left fourth nerve palsy. And you can see the imaging here, and really sort of a dural-based lesion arising from the posterior incisura. And the sagittal MRI scan where you see my mouse, that's sort of directly in the midline. You can see the relationship of the tumor. It really is a trilobe tumor arising from the tentorium, which you really appreciate on this coronal MRI scan here. And certainly, 2 of the lobules are enhancing, and then there's sort of central, sort of non-enhancing portion here. And, on the axial scans here down below, you certainly see the PCA branches going over the sort of deeper portion of the tumor and its relationship to the brainstem here. So sort of curious to see what approach everybody would use here, sort of just to open it up for conversation.
Yeah, Sean, by the way, I've been avid reader of your prolific papers. I want to make sure I say that before we go forward. Go ahead.
That's very kind of you. Thank you.
Maybe Brad, you want to take a stab at this?
Yeah. Interesting. I mean, on that kind of that coronal image that you have on the right there, I mean, definitely looks like there's a dural base to this. That I think would be concerned for this being kind of real in origin. That kind of dark area, the high bone tense area on the T2, maybe suggestive of calcification. I don't know if there was a CT before that, but also maybe suggestive of that as well. Yeah, I mean, I think this seems like it might be a nice approach for the paramedian from the left side. It'd be difficult perhaps to deal with that supratentorial portion and perhaps detaching it from there, but you'd certainly be able to get the bulk and then the portion against the tectum. So that's probably how I would approach this.
Okay, Aaron, what are your thoughts?
No, I think that's, I agree, this is a meningioma. I think a left supracerebral approach is excellent. And I think the veins are good to know where they are, but I think they're pushed anteriorly based on the location and origin of the tumor. I think it's critical in this case to minimize retracting cerebellum too much because this is relatively inferiorly projecting tumor. So in this case, I will put lumbar drain. I will really drain a lot of CSF. I really don't retract cerebellum too much, and really debulk it well, and then just lift it up rather than push down hard on the cerebellum and injure it meanwhile. So I think this dynamic retraction, excessive debulking, and letting the tumor just excavate itself, especially the very inferior portion of it, I think those are critical features. Obviously, as you get closer to the brainstem, they're going to be a very clean plane. I'm not convinced the supracerebellar is going to be challenging to take out. I think the most impressive part of this would be just handling the cerebellum with care.
Hey, Aaron, Jack here. I managed to listen to your lecture, so that was great.
Thank you, Jacques.
Why not go straight to the tentorium to devascularize it first, and then surround it, and then do what you're talking about?
Absolutely. I think, yes, I didn't mean what I mentioned. I didn't go through that detail, but I think that's critical. For any meningioma, devascularizing from the tentorium and then debulking is critical. That is a very well said statement, Jacques. And also something that I want to mention here is that I definitely cut the affected part of the tentorium, which should be relatively easy to do, and just do almost a supracerebellar transtentorial approach. One approach that would work here, just like Jacques said, is just do that transection early on, because as you cut the tentorium, you devascularize the tumor further. But in all honesty, Jacques, this doesn't have much foveoid, so I suspect this is going to be a very or relatively hypovascular tumor.
Agree. And can I ask you, unless I missed it the first 10 minutes in your lecture, the rationale behind your lateral position? I completely agree with you. The paramedian is the way to go in most. I do mine concord. I don't like the sitting. But why wouldn't you do it concord, whether left-handed or right-handed? Why not use gravity in your favor and let the cerebellum fall away from the tentorium?
No, concord is fine. I think that by concord, you really mean bringing the head up more and letting the shoulder fall away from the surgeon. I think absolutely. When I mean, I guess I have to clarify, which is, Jacques, thank you for asking me. When I mean the lateral position, I mean concord variation of the lateral position. I don't differentiate between a true lateral and concord. I really concord the semi-lateral, concord, pure lateral, all as sort of a lateral group of positioning.
Well, I mean, concord is pure prone. I mean, the patient is completely on their belly. Yeah, unless I misunderstood your pictures, did you mean maybe 3/4 prone? Is this how you put them? Or
Okay. I do 3/4 prone. If you're referring as concord as completely prone, I never do that. I haven't done a concord or full prone position for past decade. The reason I don't do that, Jacques, is I like to sit, and the concord position provides gravity to clear the field from the fluid, and so my suction is actually another dissector, and I think that advantage is significant.
Okay, yeah, I misunderstood your picture. I thought it was a pure lateral position.
No, it's more of a. It's more. That's a. Thanks for clarifying that, Jacques. It is a concord or semi-prone, semi-lateral position. That's the position I use. Does that make sense?
Yeah.
Okay, so Shane, so what'd you do?
Yeah, so, when I looked at this case, I guess sort of how I approach any ectoaxial tumor, I thought, I always look at the site of origin. I thought this was arising from the posterior incisura. Sort of some of the comments earlier that alluded to sort of the blood supply for this. And so, certainly, my thought is I want to get to the blood supply early for this, so to be able to incise the tentorium and, assume that perhaps there are going to be some small arterial feeders from the distal PCA and SCA branches to be able to have early access to them. Given that central sort of non-enhancing portion, my worry was that this was not going to be a softer tumor. And so it wasn't going to be one that would easily fold into a neural corridor. So those are sort of the general things I was thinking about. And then, with sort of the pineal region, looking at the deep venous system. So I did get an MR venogram, and the vein of Galen was certainly superior and anterior to this. What I was worried about, as Aaron had alluded to, is that the inferior pole of this tumor projected pretty low below the tentorial surface of the cerebellum. And so I was worried about having to retract too much on the cerebellum. In this case, this was earlier in my career. What I elected to do was an occipital transtentorial approach. I think now probably would have done a paramedian supracerebellar approach, but nonetheless, for this one, I did an occipital transtentorial approach, working in interhemispheric, but also suboccipital transtentorial. And so, I positioned the patient lateral left side down, and, with the craniotomy exposing really the sigmoid sinus and the ipsilateral transverse sinus, and really skeletonizing that. So when you open up the dura and retract it, you really opens up that corridor in the midline and suboccipital. And of course, in this case, when you first open up, I'm like, man, this is going to be a very narrow corridor. But, I didn't put a lumbar drain in. Just with hyperventilation and mannitol, the brain just started relaxing. And what I did early was just incise the tentorium. And so in that image on the right here, the transverse sinus is to the right of the image, and the dashed line here is really where I began that tentorial incision underneath the occipital lobe and suboccipital region. Of course, whenever you're incising the tentorium, you always worry about any venous lakes. In this case, luckily, there weren't any venous lakes, beyond the anterior to the transverse sinus. And so I've, begun that dural incision along the tentorium and carried it up towards the midline, towards the straight sinus in the midline. And, one of the things, you begin to appreciate when you start making that dural incision is that in terms of the angle of the tentorium in the midline. And, certainly when you're doing like a midline supracerebellar approach, you certainly appreciate that the tentorium is sort of like a cathedral, and the straight sinus sits at the top of that cathedral. And with this occipital transtentorial approach, when I was making the incision and carrying that dural incision towards the midline along the straight sinus, the mistake I initially made, as you can see on the image on the right side, is that here's a straight sinus, and there's still a fair amount of dura just lateral to that I could have incised. So certainly initially I had some reasonable exposure of the tumor, but that disease along the midline and extending a little bit towards the contralateral side I couldn't see. So I re-incised all this dura, going closer up to the straight sinus just to open up that corridor in the midline. And so certainly after incising the tentorium, the tumor was relatively avascular, but as I started debulking it, you can still appreciate that still some more arterial supply to the tumor. And so, I always am paranoid about injuring any vascular structure, so I always like to find them very early in the operation. Certainly it also helps with devascularizing the tumor. And so this image on the left here, the retractor sort of gently holding up the falx, and I'm dissecting the superior pole of the tumor, and here's really the distal PCA branch there. And there were small arterial feeders there that I selectively identified, bipolared and cut, and then that completely devascularized the tumor. And then this image on the right here is really the midline portion of the tumor that's being dissected off of the brainstem there. Just above that superior, you can see the rest of the brainstem. And at this point, basically the rest of the tumor peeled away. And that's sort of the exposure you're left with, that was left with at the end, with all the structures identified. And, on pathology, this turned out to be a solitary fibrous tumor, WHO grade 3. And of course, this used to be sort of in the older classification, anaplastic hemangiopracytoma. And so, here are the post-op scans for this patient showing a gross total resection. Of course, with these occipital transtentorial approaches, you always worry about their visual exam. So I do get visual field testing, and had good visual fields post-op. Patient went on to get radiation therapy given the histology, and the 3 years out, certainly with no evidence of disease. That certainly open to comments and thoughts.
It's an excellent result, Sean, and you can't argue that this wasn't the right thing to do. So I think that was just perfectly fine. It's just, again, it's my personal preference is that I think doing this operation via the rad you did, again, with an excellent result, probably took you, I would say, what, 5 or 6 hours? Am I correct?
Yeah, it took about 4.5 hours.
Yeah, I think I think if you do it supracerebellar, probably can do it less than 50% of that. So I have a preference over a shorter surgical time for the patient, I think, but you can't argue with a good result.
Yeah, great outcome, Shane. I think that the other key aspect that you kind of breezed over was just the importance of kind of making that dural cut so proximal to you, far away from the tumor and far away from the sinus, and then kind of so that you could kind of cut the dura going away from you rather than trying to go to the distal part of the dura and then cut towards you. I think that's a mistake that a lot of junior people make. And you get to the tumor, you want to get to the tumor, and then you get to the tumor, and then you have to cut the dura back around it. But by finding it early, you can kind of devascularize it in the normal dura going towards where it gets really hypervascular in that section. So that was a nice maneuver. Nice job. I would have taken the same approach.
Hey, Sean, can I comment on your opening of the dura over the occipital lobe?
Absolutely.
I think it's too generous. You know what I fear with these things is when the dura is open so wide that occipital lobe strangulates with gravity on the edge. So if I use this approach, I make a point of making that opening not very lateral at all. But I do use lumbar drain so that occipital lobe sinks in intradural rather than you know what I'm saying, jumps out at you.
No, absolutely. I think in retrospect I would have done that differently. I think what I was worried about at the time was that portion of the tumor extending laterally along the tentorium. I guess that's where the advantage of the paramedian supracerebellar approach is, that lateral extent that's attached to the tentorium, you get access to that. And I think my craniotomy, I extended it so far along the transverse sinus, and I opened up the dura just so I can get that suboccipital row.
Very nice. Let's see the next case.
Okay, so Winnie Lee or Brad?
Sure, happy to share. Let's see, I think that's it. Great. Thank you very much for having me join this very interesting topic and amazing group to be with. This is a case that I met a few years ago, 10 years after the patient's initial presentation, which was as a 27-year-old man with generalized seizure, nausea, headaches for several months. He went to an outside hospital and had the only imaging that we had from that point in time was this CT scan. He underwent by report, a teal-velar approach for resection of this mass with fairly subtotal resection, as you can see here by the craniotomy and the origin of the tumor, which was superiorly based to begin with, and the most of it remained. He had a 3-month extended hospital stay, a number of neurologic complications, which because of his youth mostly got better, but continued gait instability, eye movement difficulties, and ultimately underwent a shunt for the continued obstructive hydrocephalus. So the pathology from that initial surgery came back as a grade 1 pilocytic astrocytoma with a BRAF fusion. And before I go further, I'm curious for the audience, had you met the patient at that point in time, what would you have elected to do? Any additional surgery, observation to give him time to more fully recover, potentially think about chemotherapy or radiation? Dr. Cohen-Gadal, what would you have at that point?
Would you mind putting the images up again, please?
Absolutely, and they are limited, but this was the post-operative CT that we have available.
And how about the ones before that?
And this is the pre-op, which also shows that the mass was mostly superiorly based with a dilation and a cystic component inferiorly.
Mm-hmm. I always try to avoid the fourth ventricle if I can, because usually the risks are much higher if you can go supracerebellar. What I see here, again, as you said, the images are limited. I think the bulk of the tumor is supracerebellar. What you see inferiorly, I think, is some edema and hemorrhage. So I would have gone supracerebellar. I think the surgeon elected to go telovelar. Can you put the image up, the sagittal view again? I think because of that, they probably limited exposure of the pineal region, and there's a fair amount of tumors left behind. Obviously, it's easy for me to sit here and say that it could have done this or that. We don't know the circumstances in surgery, but my preference would have been a supracerebellar. I would have removed bone over the foramen magnum and more off of the midline, just to have the option of to go telovelar if I need to. So I would have gone supracerebellar first lateral, but would have provided myself with an option to go telovelar if necessary.
For these cases, would you have put in an EVD or a shunt, or just taken out the tumor and potentially, avoid permanent CSF diversion?
I mean, obviously, the third ventriculostomy have not been available at that time. What I would have done is I would have done an EVD, standard right frontal EVD for the surgery, make the patient recover, and then if I can wean them off the EVD, I would then do a third ventriculostomy.
Great. So this patient, by his treatment team, was observed, probably because of the very difficult course that he had. And 10 years later, came to us because his tumor was slowly growing. As you can see on the previous CT, a good part of this was there, but specifically it was this portion superiorly that was growing over every 6-month scans. Neurologically, he had been recovering fairly steadily over 10 years, meaning he's independent, walks with a cane, and has accommodated mostly to his double vision. But he came to us specifically for the initial question of, could this BRAF fusion tumor be amenable to a clinical trial? And our neuro-oncology team was gracious enough to take a second look and ask for a surgical opinion of this. So at this point in time, clearly I elected for additional surgery, but I'm curious to see if anyone else would have thought otherwise.
Jacques, what do you think?
So I pursued this exactly as you had discussed, with a supracerebellar infratentorial approach, partly because as evident on the MRI before, partly because he had so much space from the prior procedure, as well as the pathology created that corridor. And so I used a modified Concord position, I think perhaps similar to what you had described, in which one side of the body is bolstered in a larger role than the other. The arms are resting comfortably at both sides, so there's no hanging arm or worried about positioning at the axilla. And most importantly, it allows the bed to be very low without risers on the bed, and for me to be sitting throughout the case and rest my considerably shorter arms than yours on the patient's back to allow for ergonomics throughout the case. And the head is tilted also to allow for ease of approach. So in this particular view, this is the bilateral transverse sinuses on a kind of a expanded craniotomy that exposes a little bit of the occipital region, but mostly just for mobilization of the dura around the transverse sinuses. And then a, what I call Mona Lisa smile dural incision, about 0.5 centimeter parallel to the sinuses, with a tiny cut towards the exact limits of the sinuses, the dural tack-ups to flip it over and mobilize so that we have a direct trajectory over the straight underneath the tentorium. We place small cotton balls saturated to be bolsters for the operative corridor, our version of the Layla. And there's a midline vein that was preserved throughout the surgery, although I suppose many folks would say it can be taken with impunity, but it's been our practice to save every possible vessel unless we absolutely can't. And this is the resection. What was fascinating about this tumor is I thought, being a tumor, that it could be debulked. But really, the vast majority of this tumor, except for the very anterior growing kind of portion above the incisura, was almost like the AVM capsule. The moment, you know, it's nicked, there would be profuse bleeding. So I really had to tackle the tumor almost circumferentially and was not amenable to debulking. And so here, whoops, I apologize. So here, when we get to the straight sinus vein of Galen, you can see the intimate relationship of the tumor with each of these veins. And that was really the great bulk of, I apologize, I'm not sure why this video is jumping around. The great bulk of the dissection was really spent on trying to dissect the tumor out from the venous complex. And for me, the basis of that is the ease and comfort of the ergonomics, and also being able to do bimanual dissection with a third hand in there to allow for the suction, so that we could actually use micro scissors and jeweler forceps. And then ultimately the tumor was excavated in essence in its entirety. Still around that midline vein that I think I really kept mostly as a technical exercise, but the patient thankfully did very well. And 2 years later, he's still, you know, with a pristine scan with an open aqueduct, and, you know, back to work.
Very nice, Linda.
Great job, Linda. Was the pathology the same?
The pathology was the same. Yeah.
Great. Yeah, I mean, removing it without taking it pieces is challenging. So that's nicely done, and I think that was definitely the right approach. I'm not sure if anybody would have done anything different. Okay, outstanding. Brad?
Yeah. So this is very much less about the actual you know, procedure itself, and more, I think, getting to the point of Dr. Congadal's lecture. And again, I think I'd be remiss without saying, you know, how much I personally appreciate kind of your efforts in terms of the Neurosurgical Atlas and the video teaching. I can't imagine there's many residents or junior faculty come out in the last several years who have not benefited tremendously from watching the videos and the work you've put together. I think it's made a tremendous impact kind of in the field and in the way a lot of these residents are learning these procedures, and it really kind of expanding your horizons. I think, you know, we all come from, you know, an individual program where we may have learned a specific way of doing things, and kind of alluding to what you had said at the beginning of your talk, you know, that we kind of get ingrained in doing it that way, and seeing the way 10 different surgeons do an operation is, I think, immensely beneficial. So this kind of gets to that. You know, again, this is a specific case of 50-year-old gentleman presented with several days of progressive headaches, again, this pineal region lesion. And this was very early on in my kind of experience as an attending. And so the way I had trained doing these was with a midline supracerebellar infratentorial approach in the seated position. And so, you know, that's the way I trained. So figured that's the way I would do it. And so kind of honestly hadn't really thought about doing it any other way at that time. You know, we did it via that way or the occipital transtentorial approach, depending on the venous anatomy, but really not much familiarity or discussion regarding this paramedian approach at the time of my training. And so did it in the sitting position with all the typical preoperative things that, you know, fortunately you don't really have to think about in these other approaches like an occipital transtentorial or a paramedian approach where you're not doing it in the seated position. Preoperative TTE with bubble studies to ensure there's no intracardiac shunt, and then standard intraoperative monitoring, again, very much aimed more at the positioning than the actual operation itself, that you would do in the seated position with transesophageal echocardiogram, long arm CVP or PICC line, all the things that are required for this approach. And so as far as the surgery, again, small amount of air entrained with the initial burr hole, you know, our anesthesiologists are able to sense this with exquisite accuracy and sensitivity with the transesophageal echocardiogram, which is really the gold standard. hemodynamically stable. You do the classic things that you learn for in these cases or on your boards. You flood the field, you wax, and we continued. He was not unstable. After completion of the craniotomy, large venous air embolism noted on the echo, acutely hypotensive, drop in end tidal CO2, was wax covered with a wet lap pad. You turned and rotated the bed to try to trap air in the right atrium that could be aspirated, and then hemodynamically supported with epinephrine. After recovery of his blood pressure and stabilization, air was then noted on the left side of the heart on the echocardiogram. So despite having a negative bubble study, had air on the left side of the heart, which is obviously concerning. That obviously puts you at risk for paradoxical air embolus and stroke, and presumptive diagnosis at that point of perhaps transpulmonary AV shunting, which had been reported before. All the monitoring had remained stable throughout the operation in terms of EEG, SSCPs, and MEPs. We ultimately proceeded with the resection as he stabilized. This was a pineal parenchymal tumor of intermediate differentiation. We ultimately ended up with a nice resection. And he did well following this, but again, initially did have some mild left-sided hemiparesis, some mild neglect. And you could see these small cortical infarcts that were almost certainly related to this paradoxical air embolus. Again, he ultimately improved, underwent external beam radiotherapy. Again, this was many years ago, and he's been on observation since. And I just think this is an interesting case, again, getting to some of the positioning issues. And I think one of the, as we many times are a slave to our last kind of complication or issue in a case, this kind of, I think, was a turning point where I said, man, is there a better way to do this? And I think many of the points that you've touched on, I think it pushed me towards doing these really exclusively through the paramedian approach. I think the ergonomics being a tremendous one of them. I happen to be a tall guy with long arms, but nevertheless, those seated supracerebellar midline approaches tended to be very exhausting cases. And I think eliminating this risk of the venous air embolism and the additional workup and anesthetic considerations that are required for those. The two things I would either both question for you, Dr. Cohen-Gadol, in terms of learning this approach with the orientation. I found stealth to be really useful, and knowing that you have accurate stealth, because when you're off midline, I found that's probably the biggest learning hurdle for this approach. Is you're used to being midline. It's very orientating to be midline, and that paramedian approach throws you off, I think, the first couple of times you do this. And do you have any other tips in terms of how to orient yourself or to maintain that orientation when you do the paramedian variant of the supracerebellar approach?
Yeah, this is a tough case, Brad, a very tough case, because so much of the tumor is actually above the tentorium. Number one is that you're right, it's very disorienting because you may end up on the other side of the tentorium, because that's what pushes you. So if you start on the left side, you may end up on the right, under right tentorium, not knowing where the tumor is. And that is the first pitfall I see most commonly people have, is they just dissect before you know it, you put a stealth there on the right cerebellum and started from the left side. So stealth is important, and obviously dissecting this in the lab and getting some experience is critical. But there's so much thick arachnoids in the area that if you're not careful, and if you don't dissect the arachnoids to let the cerebellum fall down from the posterior brainstem, this can be a very long day, and it can be very, very painful. This is a long working distance of an operation. Somebody who has to be very comfortable using the mouth switch, bimanual, good command of the anatomy, and just go for it and be very deliberate. So that's the first one. The second one, Brad, is, and again, it's easy for me not being in your shoes in the operating room to make a decision. I would have strongly stopped the operation at the time where there was air on the left ventricle. I have a lot of respect for people who describe their complications, as you have done here. So I think we learned a lot about this case more than other cases or my cases we discussed today, which I think is that if you have any shunting within the heart, you got to close the case. that's at that time to leave, come back later in a lateral position. So if I have any problem controlling air, I immediately close. In other words, I flood the field with water, with fluid, saline, covered with a sponge, wait a few minutes, where the venous bleeding, obviously bring the head down first, or at the same time as soon as you can, and then plug the bleeding points in a more, down position. If that doesn't fix it and you go up again and you're having issues and you're having any shunting across the septum in the heart, there's no question. I think you got to close and come back because of the air embolism that you see on the brain and the infarcts associated with that. So I think venous air embolism has to be taken extremely seriously. I have seen it do a lot of damage, and again, it's easy to retrospectively look at other people's cases. Overall, this is a very difficult case, I would say.
Yeah, thank you. Yeah, I agree. I think it's, you look back and, maybe it's hubris sometimes. I think, he had stabilized hemodynamically. There was that shunting across the left side, not through the heart, which there was no perforated septum. And I think it felt at that time with stable monitoring that we had made it to that point to continue. But I agree. I mean, I think that's a very important kind of stop point to really stop and consider how important it is to proceed in that operation versus closing up and then coming back another day.
Agreed.
Great case, Brad. Thank you so much for sharing, and there's a lot of learning points in there. I think the other thing that doctor that you said too is just that you see all these anatomical dissections and you see all the four veins coming down, the vein of Galen, and everything is so prettily outlined. But the first time you do it, there's all these arachnoid planes. It's distorted by the tumor, and you get in there and you're looking for that perfect anatomy that you see in the Roten book, and it's just not so apparent. And so being alert to that is key. Alert to that is key.
Well said.
One more minute. I have one case too I'd like to share, if that's okay.
Sure, go ahead, please.
Last minute. So this was a couple years ago, a 60-year-old female with worsening headaches and some occasional diplopia, and presented with this MRI here. Highly likely that it was going to be a falcotentorial meningioma just based on the dural involvement of this. But the interesting part of this case is just, what do you do with the venous anatomy in these cases where the tumor is really involved in going into the vein of Galen and the straight sinus, and also what your approach would be. So if you look, obviously here it looks very much below the tentorial and the sagittal cuts. But you could see on the coronal cut here that there's a large part that's above it. And if you look at the lateral sagittal cuts here, you could see here's the tentorial edge and here's the two kind of areas. So I got the MRV and it showed that the vein of Galen, inferior sagittal sinus, and the straight sinus was out, but I didn't trust it. And I really wanted to know that to whether or not it could come around the entire tumor or not. So I got an angiogram purely just to understand the venous anatomy. And you could see here that there is collaterals kind of this vein that's coming down and going over top of the tumor. And even a late run showed that there was almost minimal filling at all of the straight sinus, and the vein of Galen was essentially out. And so I felt fairly confident going in there that was going to be what I was going to find, and this ability to kind of take all of the dural margins and dural edges that it was attached to would be the way to go, as long as I preserved these kind of veins that have been forming along the way.
Mike, I'm going to say that angiogram was an excellent idea. I would definitely do that in this case. I would say that even if there are very minimal veins, I would be very careful when you go in the OR, because I've been surprised that, it looks avascular, and then you go there and suddenly you see all these veins in this area that they weren't very clearly observable on the angiogram. They were occult. So just because it means that there's nothing there in that region doesn't mean that when you go there, you can just take the entire sort of area of the dura that used to contain the vein of Galen and straight sinus.
Yeah. So Shane, maybe any ideas of approach, or how would you approach this one?
Yeah, I mean, this is a tough case. You know, my feeling is if you did a purely a supracerebellar approach, it's gonna be a long reach by the time you get down to the anteriormost aspect of the capsule. You know, this is where I probably favor more of a supratentorial, transtentorial approach to something like this, like an occipital transtentorial.
Yeah, yeah, I agree. And which side would you prefer?
I would probably go from, you know, from the left side.
Yeah. Any other comments, Dr. Kong at all on that?
I would do this supracerebellar just because I'm so comfortable cutting the tentorium from below. And the moment I cut the tentorium from the left side, so I will go in, cut the tentorium, and then I'll be looking straight on from the left across this tumor. This posterior fossa in this patient is so relaxed. Spaces are so generous. I suspect if you put a lumbar drain in this patient, you have a huge corridor seeing this tumor all the way to the third ventricle and further.
Yeah, no, those are all good points. I was worried with how much of this kind of left-sided area was going posteriorly. Linda, would you do anything different?
May I ask, on the T2 MRI, did it suggest if this tumor was soft or firm?
Soft.
I agree, you know, with everything that you've done, including the angiogram and the philosophy that the approach to a meningioma is dictated by the veins. So if the veins are displaced superiorly, then I would also at least initially consider a supracerebellar infratentorial approach with the hopes that creating that space and especially with the promise of a soft tumor that it may come down. But I probably would also prepare the patient for the possibility of a second stage if necessary, or prepare intraoperatively for that additional corridor coming from the top as if it turned out to not to give. But I agree with everything that's been said so far.
Yeah, that's a great point. I've learned that now from all of the experts that have come on here, and always prepare the patient for a second surgery if needed. Brad, any other thoughts before I?
Yeah, no, I mean, I agree with everything that's been said. I would probably do this through an occipital transtentorial approach. You know, it looks like if in fact a lot of those veins are occluded, those dominant veins are occluded, and that primary draining vein runs superiorly towards the superior sagittal sinus, and you're coming from below, that might be the last thing you see. And that would concern me. So I would probably feel more comfortable doing this through an occipital transtentorial approach. But again, I agree, there's a big infratentorial component, and depending on the consistency and the adherency, this may require more than one operation.
Yeah, and I think that I asked for a lot of advice, and it was very 50-50. I ended up coming, doing what you did, Brad, and coming from the right side to kind of get that contralateral approach. I was able to kind of come through the falx as well as open both tentorial edges to remove the tumor. But when I got down there, I found exactly what we said earlier, is that the straight sinus was open, the vein of Galen was open, and the inferior sagittal sinus was open, and that draining vein was going in into those. And so it kind of really allowed me to have that, it prevented me from really getting that kind of apex of the tentorial falx area where the vein of Galen would be removed. And then what Shane was saying before, that cathedral of not being able to see underneath coming from that occipital transtentorial approach made me leave a little bit of tumor. But she did well. This is her like 2-year follow-up MRI. So you can see there was a little bit of residual left underneath where the vein of Galen was kind of involved. And that was kind of that hidden part of where it was very difficult to see from above. But she's done great. She's doing marathons, and we're watching this closely. It was a grade 1 meningioma, and if we need to radiate, if it grows, we will.
Good work.
Okay, well, that concludes everything for tonight. I just want to say thank you again to all the speakers and for panelists for taking the time out. We really appreciate it. It was an excellent discussion tonight. I hope everybody stays safe at this time period, and we hope to see you soon.
Thank you again.
Thank you. Good night.